This week on the BackTable Podcast.
I kind of got a rep for helping people avoid surgery. I don't push them not to have surgery if they're like really, really determined. Despite the fact that your thyroid gland is jacked up, it's still doing something, and it is helping keep you on a level to some extent. It also has calcitonin in there, which you need for bone health. And if you take all of that out, we don't really know the implications of not having a natural source of calcitonin in your body because there's not good research on that. A lot of people who've already had radiation for their thyroid, I treat them too. So that's another big subset of people that I treat is people who have had their thyroid irradiated either from head and neck cancer or because of Graves' disease antibodies.
Hi, everybody. Welcome to the BackTable ENT Podcast. We're a podcast that focuses on all things otolaryngology, and we've got a really great show for you today. Thanks for stopping by. Hey, everybody. Welcome to the BackTable ENT Podcast. My name is Ashley Agan, and I will be your host today. I'm a general ENT, and I'm here today with Dr. Dana Gibbs. Welcome to the show, Dana.
Hi. So thank you so much for inviting me to come, and I'm really excited to be here.
Yeah, today we're going to be talking about Hashimoto's thyroiditis. And before we get into it, let me give you a proper introduction for those of our listeners who don't already know you. Dr. Dana Gibbs is an educator, a hormone expert, a board-certified ENT and allergist. She attended medical school in San Antonio, Texas, and trained in otolaryngology at the University of Kansas. She practiced in private practice otolaryngology in Arlington, Texas for 23 years. And now Dr. Gibbs speaks online, presenting workshops that introduce physicians and patients to unique solutions of an integrative hormone practice. She recently retired from her ENT practice and opened Consultants in Metabolism, a direct care practice for thyroid, metabolic, and hormone management for women and men. The practice is located in North Texas and offers live and virtual visits. Before we get into it, I would love for you to just kind of give us a background of, how an ENT got to care so much about Hashimoto's and, other benign thyroid disorders.
Sure, absolutely. So my training was super typical. We did lots of thyroid nodule excisions and partial total thyroidectomies, and I continued doing those in my private practice, but I also, because I moved to Texas and because allergy is, I was doing general ENT. Because allergy is such a huge thing here, I very, very quickly realized, oh my gosh, I need to learn allergy because I would get my, nasal polyp patients and my CRS patients and send them to the general allergist, and they would come back with a prescription for Allegra. And, this was many years ago, of course. And I'm like, dude, I could have done that. And so I went to AAOA. I got the AAOA fellowship. I started treating allergies, giving people shots, sublingual drops, and they did pretty well. But there was a subset of people who would come in and they have all these symptoms, and you do their tests and there's not a whole lot there. And you're like, oh, I can't, what can I do for you? I don't know what to do for you. But it's also more personal than that because I had a really rough time getting through residency. I was super exhausted, tired all the time. I was cold all the time. My eyebrow hair fell out. A lot of my hair fell out. Lots and lots of stuff that today I look back and I go, I was classic hypothyroid. But I didn't realize that at the time. I went to the health clinic and they were like, oh, here, take these antidepressants. You're just depressed. And I'm like, okay, that's fine. It didn't do, what it was supposed to do. But I struggled to get through residency just because my energy level was so very low. And when I got out in private practice, it got a little better. And I went from drinking, a pot of coffee today to, 2 cups of coffee a day. But I was still pretty tired and I was definitely still cold all the time and all those other symptoms. But I was going to allergy conferences and I went to one, and you know how you do when you've heard the same lecture twice already. You're like, I don't need to listen to this one again. And so I wandered into another lecture hall, and there was this guy, and he was talking about people who are hypothyroid, but their tests don't show anything. And he went through the lecture, and I swear to God, I had to pick my jaw up off the floor because he listed this list of symptoms, and it was like, oh my God, I have every single one of those things. And he couldn't tell me how to test for it. He said, you just get a gestalt. And I'm like, yeah, that's real helpful. Thank you. But I was kind of desperate at that time. And I went back to my doctor at home and I said, you know what, can I please try this? And I started myself, well, he started me on Armour Thyroid. And it was like this miracle. It's like all those symptoms went away. And I had never had abnormal thyroid labs. And so that kind of started the journey. It's like, okay, what is this? What's going on? And started looking. And finally, a few years later, I came across a mentor, also an ENT, coincidentally, who had the same issue about 20 years earlier and had developed a protocol for identifying, testing, and treating that made sense to me. And it was backed up by literature. And if you go to an endocrinologist and you ask them about this, they completely poo-poo it. They're like, that's not legit. That's not a thing. Until about the last 10 or 12 years. And then endocrinologists have started treating people, admitting, hey, there's a subset of patients who don't get better when you treat them with levothyroxine. And if you give them T3, they do feel better. And they still, even the European ones who seem to be more open-minded than the US, they still don't follow this protocol that I follow. But it's really remarkable how well it works and how consistent it is. But the literature and the research is still pretty incomplete as far as mainstream endocrinologists picking up this and going, okay, I now know how to teach a family medicine doctor to identify this subset of normal TSH, obvious thyroid symptoms. And it became gradually a bigger and bigger part of my practice because those allergy patients, the ones I was talking about, whose tests didn't really show much, or their sinusitis was just horrible and you do their surgery and they just don't get a whole lot better. I started, once you see that list of symptoms in your head, you can't unsee it. And I would say to them, hey, you know what? I think you have hypothyroidism. And we would get the tests and I would start them on some thyroid medicine while I was waiting to do their sinus surgery, for example. And 6 months later, they'd come back and I'd be like, well, you ready to get your sinus surgery? And they'd be like, no, I don't need that. That's all gone. I don't need that anymore. I just need a refill on that thyroid medicine. And I'm like, what? So that story kept happening. And it became a word of mouth thing. It became a gradually bigger and bigger part of my practice until I almost didn't have room for surgery patients anymore. And that's kind of where it started.
Yeah, I think when doctors themselves become patients, it changes, how you look at certain, at treating certain diseases.
Yeah.
Because when you're able to kind of sit in that seat and be in the patient's shoes, it changes things.
Yeah.
And, when you think about evidence-based medicine and wanting to really stick to only treating according to, the highest level of evidence, there's going to be patients that are left out because the evidence just isn't there yet.
Yeah.
And so the question is,
exactly.
Do they just have to wait until the research catches up, or do you kind of step outside the box and try to meet them where they're at?
Yeah, exactly. And in private practice, I didn't really feel like I had the bandwidth to do some kind of an organized study. I really do wish some ENT somewhere would do it. But, my N of 1 became this very, very consistent clinical outcome of, I even had people who had come into me for allergies or sinus, and I did this, this thing, I had the same thing. Hey, I think maybe you have this thyroid thing, who incidentally had been infertile. Middle-aged women who had infertility, multiple miscarriages, blah, blah. And all of a sudden they're coming back to me and saying, I'm pregnant. Now what do I do? And I'm like, what do you mean you're pregnant? You have infertility. They're like, no, you fixed me. And I'm like, what are you talking about? And the third time that happened, I was like, okay, there's something going
there's something here.
And I really started looking into it. And it's like, yeah, that early trimester miscarriage is a hallmark of Hashimoto's disease. And that kind of segues us into talking about Hashimoto's, which is what I really came to talk about. But I'm sorry, I choke up when I get to talking about that because, I did something that changed that person's life. And wow.
Yeah, it's not a small thing. One thing I did want to comment on that you had mentioned earlier, just talking about residency and being tired and struggling. It's hard to know if there's a medical problem or if it's just residency. Like, for example,
exactly.
Like for me, I had a lot of symptoms of like fatigue and being tired and ended up, when I got labs, I was really anemic, like super anemic. And, but I had just thought, residency, it's just residency. It's, we don't sleep, we're going. And so, and then we don't go to the doctor, because we don't have time. So
well, the second or third time you go and they say nothing's wrong with you, you're taking antidepressant. You're like, okay, I'm not going back.
For sure. So let's get into Hashimoto's, kind of our topic for today. So just to kind of set the stage and for background, maybe for listeners who don't know much about Hashimoto's, can you talk a little bit about just kind of like a brief overview of that?
So Hashimoto's is autoimmune thyroiditis, where the autoimmunity is directed at thyroid peroxidase and thyroglobulin, which are the support proteins and the manufacturing proteins of the thyroid hormone inside the thyroid gland. And it's really common. I mean, if you do random sampling of U.S. populations, the estimate is 15% of people have some evidence, either thyroid antibodies or lymphocytic infiltration of their thyroid on a biopsy. So it is super, super common. I mean, 15%, that's like, 30, 45 million people. It's a lot of people in the U.S. And it's the most common cause of benign thyroid nodules. And the reason those thyroid nodules happen, when you get something back, when you get a biopsy back and it says it's an adenomatoid nodule, not a follicular adenoma, not a benign adenoma. What has happened is the inflammation happens, it destroys portions of the thyroid gland, and then, it's a relapsing, remitting type of a condition. So scar tissue has a chance to form in the thyroid gland, and then the follicles that now have to regrow to kind of repair the damage are constrained by that scar tissue. So they grow in this nodular pattern. And some of them can get quite large, 3-4 centimeters. And you're like, oh my gosh, that's thyroid cancer. We have to take that out. And so people will come in and have these nodules removed, which leaves them then with even less thyroid tissue than they had before. So it's something that ENT doctors see basically all the time. And it slides right by because all they think about is, I have to take out this thyroid nodule, and then I'm going to send them back to the endocrinologist. Well, I will tell you, 9 out of 10 endocrinologists that I have seen will go, oh, your TSH is normal, go away. And the patient's like, yeah, but I've gained 50 pounds. I feel like crap. My hair is all falling out. And you sit there and you look at them and you can look through their hair to see the top of their scalp. Their hair is so thin. And so, it's kind of like that list. I can't unsee those people.
And what is that list of symptoms? Like, do you screen for that? Like, or before, obviously now this is kind of like your main focus, but in the past, when you were in practice, when you would see a patient with a thyroid nodule, would you kind of screen for that list?
Yes. I just added it to my systems review. The MA's filling that out. I just added it. Okay. Are your hands and feet cold? Is your body temperature low? Are you cold all the time? Do your hands ache? I mean, my hands ached during residency. And I just thought, oh, well, it's because I'm in the body and they're sticking out there and they're cold. I thought I had Raynaud's. That's how bad my hands were. Constipation is a big one. And for some people, really, really big. So one of my fellow ENT colleagues that I didn't meet during training, but I met afterwards, actually had the same issue. And her main symptom was constipation, to the point that she ended up having her colon removed because they couldn't figure out what was wrong with her. And I was like, oh my goodness, that's so bad. And she didn't figure it out until she became pregnant. Her GYN gave her thyroid medicine and all of a sudden she was better. It's like, what? But it was too late. She'd already had the surgery. So hair, dry, itchy skin, sometimes hives, vertigo. That's another thing ENT people see all the time. If you get a vertigo patient and it's not PPPV and you're like, I don't know what to tell you, it can be that. Weight gain isn't super common. People who come in who are obese are like, oh, this is by thyroid. I'm like, no, maybe 10% of your weight gain is your thyroid, but the rest of it is other associated stuff. I mean, I was thin. We never had time to eat. I was thin. And so nobody looked at me and goes, you have thyroid. But you look at that list of symptoms, the low body temperature, the slow pulse, the brittle nails that break, the thin hair, all that stuff. And yeah, I would get to where I would walk into the room with a patient and look at them and they're puffy around their eyes because the autoimmune disease infiltrates glycosaminoglycans around your wrists, around your eyes, on your shins, that are similar to the way Graves' disease does, but not so much the lid lag and all of that. So I would get to where I could just walk in and go, this is another hypothyroid patient. And, they would be, why are you here? Oh, it's sinus, it's this, it's that. I'm like, okay, we do their allergy tests, it come back, not much. And I'm like, let's check. Let's do my protocol to check your thyroid, which we'll get into in a minute.
Before we do that, before we move on about Hashimoto's, do we know what causes it? Do we know, are there certain risk factors? Is it more common in women versus men?
Yes. So it is an autoimmune disease. It is frequently kind of the sentinel autoimmune disease. And it's triggered by stress. It's triggered by a bad diet. It's triggered by high or low levels of certain minerals in your diet. It's iodine and selenium were the two I was thinking of there. It's very, very common after pregnancy. It is 5 more times more common in women. And it is very, very frequently unrecognized for years and years and years because we don't think to check for it. If your TSH is normal, then we don't think, oh, well, we need to do those thyroid antibodies and see what's going on. The problem with the thyroid antibodies is it still misses about 10% of the people. And if you feel their neck and they've got a thyroid nodule and you biopsy it and it has lymphocytes, whether or not they have antibodies, that's what it is.
Well, so what is your protocol when you're seeing patients and you decide, okay, we need to look into, this possibly being related to Hashimoto's? We talked about TSH is, I assume you still do TSH, but TSH alone is not sufficient.
Correct. So TSH alone is not sufficient. And one of the hallmarks of Hashimoto's disease in particular is this relapsing and remitting. So when the immune attack is happening, their thyroid gland will release high levels of thyroid hormone in their body. So it'll go very high and it'll go very low and very high and very low. And one of the things that happens when you have high T4, whether it's coming from the thyroid gland or from an autonomously functioning nodule or from somebody being given levothyroxine, is that it turns off the production of T3. And in thyroid physiology, your body makes T4 and a little bit of T3, and then the T3 goes out into your body cells, and T4 is converted to T3 in the target cells. And then the T3 goes to the nucleus, activates the protein cascades, and does all the things that thyroid hormone does to stimulate your metabolism. And when you have high T4, it feeds back to the pituitary and the hypothalamus, and not only turns off the production of more T4, it also blocks, it causes a global blocking of the conversion of T4 to T3 throughout your body, which doesn't show if you don't check T3. The other thing it does is that so this high T4, it's a protection mechanism. It's like, okay, so high T4 in the setting of Graves' disease is a disaster. You just burn your whole body up. Your heart rate goes up. Everything's terrible. So your body has fail-safe mechanisms to block that. One of them is this fact that it turns down the production of T3. The other one is a parallel pathway. So T4 gets turned into T3 by something called type 2 deiodinase. And there is also a type 3 deiodinase, and that type 3 deiodinase enzyme takes the T4 and turns it into reverse T3. And reverse T3 is an inactive metabolite, but not really, because it can still bind the receptor. And this is where me and the endocrinologists start to differ, because they say reverse T3 is meaningless. It's an inactive metabolite. And I'm like, yeah, but it binds and blocks the receptor to T3. So even if you have enough T3, if you have enough of this blocker, then the relative function of your T3 is diminished because of that. And so I check the reverse T3, and then I also check the total T3. And the reason you have to compare reverse T3 to total T3 is because they are both protein bound. And it's the same proteins, and the reverse T3 is just a subset, but they're identical. So you're getting an apples to apples comparison. A lot of functional doctors have this weird fancy calculation that they try to do from free T3 to reverse T3. And then, they're going to try to measure the thyroid binding globulin and the albumin and all this other stuff. And I'm like, look, that doesn't work. It's not necessary. It creates unnecessary complication that makes this calculation very, very difficult, when you can just take total T3, divide by reverse T3, and it ought to be at least 10 to 1. That's the natural, in normal people, that ratio is 10 to 1. If it's less than 10 to 1, then the person isn't necessarily going to feel good, even if their absolute T3 and absolute T4 numbers are okay.
Okay. So saying that again, a patient comes in, their TSH can be high, low, normal, any of those things.
Yes.
You'll check total T3, total T4, and reverse T3.
No, not total T4.
You don't even worry about T4.
Total T4, free T4
okay,
I check.
Free T4. Okay.
And the reason I care about free T4 is because that's the substrate to make reverse T3 and T3. And so a lot of the mistakes that get made with treating thyroid symptoms is, for example, the patient comes in and says, I feel bad. The doctor believes them and says, here, let me give you some T4. That's the standard treatment, right? Well, the more T4 you give that person, the more reverse T3 they're going to make. And the worse, and so giving somebody T4 can actually make them feel worse if what their defect is high reverse T3 and not enough T3 conversion.
Okay. In what situations is T4 going to be preferentially converted to reverse T3 as opposed to T3?
Oh, boy. It's a big list. So high cortisol is one. So stress.
And that just tips the scales and pushes things towards reverse T3.
Yeah. High cortisol does two things. And this is a total different lecture, but high cortisol does two things to your thyroid. The first one is it suppresses your TSH. So you can be deficient in T4 and T3 and have a normal TSH if you have really high cortisol. The second thing it does is it pushes you towards deiodinase 3, which is the reverse T3. And the reason it's doing that is because, primitive stress, a lot of primitive stress was famine. It was starvation. What do you not want to do when you're starving? Well, you don't want to burn up all your calories. So let's block that so you can hibernate a little bit until spring when the food comes back. So high cortisol is one. Fluctuating intermittently high levels of T4, which would be what you see in Hashimoto's disease, because that's what the disease process is. Exogenous T4,
which is like levothyroxine or Synthroid.
Which is like levothyroxine. Calorie restriction diets. Basically, your body can't tell the difference between I want to lose 20 pounds and, oh my God, there's a famine. Your body can't tell the difference. Beta blockers. Super common. Activates reverse T3 in a big way. There are some other drugs that do the same thing. Cortisone or amiodarone is another one. And then there's a few others that I can't remember right this very second.
So those drugs will kind of tip the scales such that there's more production of reverse T3 as opposed to T4 being converted to T3.
Yes. So, and it can be psychological stress. It can be physical stress. Overexercising is another physical stress that people forget about. And then severe illness. So the way, and most of the literature about reverse T3, the research comes from the ICU. It comes from critically ill people who get what's called euthyroid 6 syndrome. And what happens in euthyroid 6 syndrome is the patient's thyroid will basically shut down and they will have these phenomenally high levels of reverse T3. It's the same thing. Your body's trying to conserve resources so you can live to fight another day, but it can go overboard. And what they've found is that the survival data is really, really bad. If you have high reverse T3 in the ICU, your chances of making it out of the ICU drastically diminish. And so what I'm talking about is basically a very, very attenuated form of euthyroid 6 syndrome. And giving them T3 fixes them, whereas giving them levothyroxine does not.
So back to our lab. So we said TSH, free T3, and reverse T3.
Free T4.
And free T4.
And then the total T3 to measure against the reverse T3. Okay. So that's the ratio. And
so the ratio is I can look total T.
Total divided by
total reverse. Or is there only one reverse?
No, the reverse T3, there's no free reverse T3.
Just reverse.
It's below the detection limit of the test. So there's no, I wish there was, there's no free reverse T3.
So when we're talking about reverse T3, it is bound to.
It's a total. Okay. It's a total protein bound number. So yeah, you look at that ratio, you look at the total amount of T3 the person has, the total amount of I'm sorry, I say the total amount, the free T3, the free T4, and then that total over reverse. And that's a test you can order from LabCorp, that ratio. And it'll give you the absolute, and the ratio. So it's really simple. And what I will find in these patients is that their ratio is 7, 6, 8, 4. The worst I've ever seen was like in the lower than 3. I was like, oh my gosh, no wonder you feel terrible. If they are at 12, that's good. If they're at 12 and their absolute level of free T3 is low, then they're still not going to feel great, but that's easier to fix than if that reverse T3 is high enough to make that ratio really crappy.
And these patients can have normal TSH, right?
They can have normal TSH. They can even have low TSH.
What about testing for antibodies? Do you also look for antibodies?
Well, yes, I absolutely do because, and I mostly do that the first time I see the patient because it gives you an idea of, okay, their inflammatory status. It's kind of like the canary in the coal mine. It's the first autoimmune disease people who get autoimmune diseases typically have. And is super, super common. And people are like, why do I have this? Well, it's because you have this autoimmune disease. I don't follow the antibodies in as near a regularity as I follow the rest of those 5 labs. And I will tell you, people will be like, oh, those labs are so expensive. And I'm like, no, they're not. Because if somebody comes to me and doesn't have insurance, I can get that whole lab set for them for less than $50. $50 for all of them. So they are not actually that expensive, regardless of what the insurance company is saying to you.
For the antibodies, you're checking TPO and thyroglobulin.
Anti-TPO and anti-thyroglobulin. Typically, if the story is right, or if the patient has a palpable nodule, I will also check the antibodies for Graves' disease, which is the thyroid receptor antibody, TRAB, or the TSI, thyroid stimulating immunoglobulin, just because sometimes you find an autonomously functioning nodule, sometimes you find Graves' antibodies, and you do treat those people a little bit different.
Mm-hmm.
So, I mean, you can still treat them, but you have to be a little even more careful.
And any other labs that you like to look at?
Because this comes along with stress so much of the time, I'm typically, the first time I'm seeing a patient, going to check ACTH and cortisol, like a morning cortisol, to make sure that they are not adrenal insufficient, because they go together. The other thing that really parallels this a lot is insulin resistance. And so I'm going to check uric acid. I'm going to check fasting insulin, fasting blood sugar, so that I can get a test called HOMA-IR. That's something I learned after ENT residency, when I figured out, none of these hormones exist in isolation, and you can't treat one, not pay attention to the other ones. If it's a woman who's over 40, I'm going to check her sex hormones for sure as well, just because that's my practice now. I wouldn't expect an ENT doctor to do that, of course. But this problem rears its ugly head when people's estrogen starts to drop in perimenopause. And so that's another thing that I will check.
Do you do any imaging? Like do you ultrasound the thyroid? And
Okay, so let's talk about that. So if you have a palpable thyroid, so I feel if I do a thyroid exam, if a person has a uniform, palpable, rubbery, hard, firm thyroid and thyroid antibodies, sometimes I will skip the sonogram and the biopsy. But if they have nodules, sonogram, biopsy, you bet. If a person is overweight enough that I can't feel their thyroid and I'm not sure, then yes, I will order a sonogram on those people for sure.
So it's still kind of sticking to your...
It's still a standard ENT thyroid workup, with the addition of a couple of extra
I hear you.
things. Yeah.
Any other testing? So we talked about labs, ultrasound, you doing an exam. Do you go through, a more extensive history? Since we talked about, with stress and other things kind of being a part of the picture. Do you dive more into that aspect of it?
Sure. Yeah. So I kind of mentioned the categories that I look at. So I look at stress, adrenal, HPA axis, sex hormones, insulin resistance. So I have questionnaire sections that cover all of those parts of the hormone system that I focus on. And so basically when I get that questionnaire back, it's not a tiny questionnaire. It's close to 10 pages. I mean, the patients are like, it took me 2 hours to fill that out. And I'm like, yeah, I know, I'm sorry, but it's important information. There are people who aren't good at handling stress, and it tends to happen when they've been traumatized in childhood or early life. Chronic pain patients, chronic fatigue patients, those are the kind of people that I have a lot of success with at this point, because I'm looking at all of that stuff. And very, very frequently I will find these people who are, and I'm not going to use the word adrenal fatigue. I'm not sure adrenal fatigue is a thing, but there are people who have overused their adrenal glands to the point that they're kind of malnourished and they need help. And so I tend to go there with those patients in addition to the thyroid. And one of the reasons I do that is because if you get somebody who's really depleted adrenally and you try to give them T3, they're not going to tolerate it. It's kind of funny when you treat somebody with T3, with liothyronine, that's the name of the generic prescription. There are problems with liothyronine because it is very short acting. I mean, it is an extremely short half, like 6 hours. And so you have to dose it 2 or 3 times a day. you can go to a compounding pharmacy and get a sustained release liothyronine. I don't think they work. I think it just decreases the amount of T3 the person gets. And so you have to do those labs once they're on treatment. You have to do them at a specific time of day, timed exactly between the doses of their medication. And so it's a pain in the butt, but it's better than, sorry, there's nothing wrong with you, go away. The patient is much more willing to tolerate taking a medicine 2 or 3 times a day when it makes them feel good. So there's that. And then there's this issue with the cortisol where it's like, okay, you have to, and I'm using really kind of unconventional stuff like low dose naltrexone and some other things to help those patients get their adrenal function kind of back up online. Other non-medication stuff like exercise, yoga, meditation, lifestyle interventions, low carb diets. I really, really am into getting people past their insulin resistance by putting them on a low starchy carb diet, low sugar diet. So there's a lot to it, but when you go in the right order with people, they feel a lot better and they're grateful and they're happy for it.
Let's say, you've seen somebody and their T3 reverse T3 ratio is low, and you say, okay, we're going to start you on some T3, and that the brand is Armored Thyroid. Is that the same thing? No.
So Armored Thyroid is natural desiccated thyroid. Armour is one brand name of natural desiccated thyroid, which is made from animal thyroid glands. It has T4 and T3 in it at a ratio of about 4-1. So it's 38 micrograms of T4 for every 9 micrograms of T3. And I generally don't recommend that for Hashimoto's patients because it also has the support proteins in it. It has thyroglobulin in it. It has thyroid peroxidase in it. I don't want to give that to somebody who's got Hashimoto's antibodies against those proteins and potentially reactivate their disease if they're in remission.
Gotcha.
So I don't use that. I use Synthroid and then I use liothyronine. And that way I can change the ratio. So that 4-1 ratio may be okay for somebody, but like the thyroid medicine that I take is more like a 2-1 ratio of T3 to T4. Somebody else might need a 5-1 ratio. And so I gain that by giving them 2 separate prescriptions. And yeah, it's fussy. Yeah, it's a pain in the butt, but it's much better than potentially triggering them to reactivate their autoimmune disease.
Okay. I'm glad I asked that.
And for a lot of patients, Armour Thyroid is great. It's a lot better than what they had before. If they go from just taking levothyroxine to taking Armour Thyroid, they're going to feel better.
Is that because there's some T3 in there?
Because there's T3 in it, yeah. So T3 is a funny thing because the FDA doesn't pay a lot of attention to T3. And so you could go online and buy an over-the-counter supplement that's laced with T3. And it's like, what? But you don't know how many milligrams is in it. You don't even know it's there, actually. You just say, oh, thyroid support. Yeah, this sounds good. I'll take it. Thinking that it's, got iodine and selenium and some other minerals in there that'll help you. But yeah, you got to be very, very careful and cautious with supplements.
Yeah.
Because there's a lot of people out there selling snake oil and stuff that'll actually harm you.
Yeah, it's tough because I think there's some value in some supplements.
Oh, yeah. No, I prescribe a lot of supplements, but I am very, very careful about what brand I give and what's in it. My biggest pet peeve is supplements that have 5 or 6 or 7 or 10 ingredients in there. And it's like, well, what is rhodiola for? Well, it's to suppress your cortisol. Well, what is this other one for? Well, it's to increase your cortisol. Let me think about that. That's not such a good idea.
All in the same tablet.
So if I give somebody an herb, I give them one ingredient. I give them an herb as if it was a prescription in a precise milligram amount.
Yeah. Yeah. And the tricky thing too, I think as a patient, when you're looking at all of the different supplements and different brands, and correct me if I'm wrong, but like from brand to brand, there can be variations in like the actual amount of active ingredient.
Yes, you're absolutely true. And that's not just for supplements. That is for prescription thyroid hormone as well. And here's a fun fact for you. The FDA allows a generic to vary by as much as 20% up. Maybe it's 20% down, 30% up from the stated milligrams or micrograms on the label. And so it turns out to be like a 50% variation from brand to brand, manufacturer to manufacturer. And so I have specific manufacturers that I insist on. And the funny thing is that when Armour Thyroid was basically vilified by the synthetic levothyroxine industry, that was the excuse that they used to slam down on Armour Thyroid and say, oh, this stuff is no good, it varies. Well, the truth of the matter is, if you stay with Armour Thyroid or if you stay with NP Thyroid, they're actually very, very good from batch to batch. But levothyroxine isn't actually very good batch to batch. I mean, and the Synthroid people actually got in big trouble with the FDA back in 2003. And, because they had been harping on, oh, Armour Thyroid's not FDA approved, blah, blah, blah. Well, guess what wasn't FDA approved? Synthroid. Wasn't even FDA approved. They had to go back. They paid some incredibly large fine. I don't remember what it was. And had to go back and redo all of the pharmacokinetic studies and stuff, which they had never bothered to do back when Synthroid first came online. So kind of a funny issue. You got to be really careful. And so this idea that Synthroid brand is better than this generic or that generic is probably true. But if you can find a good generic and stick with it, then it's probably just as good as Synthroid.
Yeah.
But within the T3, the liothyronine world, that's also very true. And I have one particular brand of generic liothyronine that I recommend exclusively.
Because you want to be taking, the same dose as, you want to be confident that you are taking the amount that you're taking so that you can monitor it and adjust it if you need to.
No, 30% when you're talking a dose of 15 micrograms, 30% is an enormous variation. And the reason I know that very, very strongly is because, I can tell if I get a wrong generic, for me personally, because I still take T3, I can tell within about a week, oh, something's wrong. This must be a bad batch. And I will go back to the pharmacy and I'll say, what is this? And it's some other manufacturer. And I'm like, well, no wonder. And patients feel it too. They're like, up until a month ago, I was feeling good. Well, did you get a new batch of meds then? I'm like, yeah, that's what it was. So it's fussy. It's very fussy.
Your patients, most of them, if they're on T3, they're going to be taking that potentially, 2 or 3 times during the day, right?
Very few 3 times a day, mostly 2 times a day.
But its half-life is only 6 hours.
Yeah.
How do you not need it more often?
Well, if I can get them to take it more often, I will.
Gotcha.
It comes in 5 microgram tablets. The smallest I've been able to break them is 2.5.
It's a little bit. So
if somebody is on 15, it makes sense to have them take 1 and 1 and 1 if they can remember to do it. A lot of patients have trouble taking it right before bed because then they say, well, now I can't fall asleep. And I'm like, okay, so take it before dinner and take it at breakfast, or take it before breakfast and before dinner, and don't take it at bedtime.
Is that because as it's coming on, you get a little bit of a, as it's kind of coming into your system, you kind of get this.
Because your blood level, you get this burst of energy. And it's like, okay, so don't take that at bedtime.
Interesting.
Take it before dinner. Fun fact, for my Hashimoto's patients, I also have them divide their levothyroxine if they're on levothyroxine, and some of them eventually need it because that's kind of the natural history of Hashimoto's, is that eventually for some people we can't get them into remission and their thyroid damage gets bad enough that they also need to take T4. I will break that in half too to minimize those highs and lows because, although we have been told that the half-life of levothyroxine is really long, it's not near as long when it's taken in a pills form as it is endogenously in your body. And you do get a big spike 2 to 3 hours after you take it, and then it tapers down during the day. And the smaller you can make that spike, the less you're pushing them to make reverse T3. And so I'll tell them, you got a 75 microgram tablet, break it in two, take half at morning, half at bedtime. That way they don't get as big of a spike.
Yeah, that makes sense. And how often are you checking labs? Like, I feel like, from what I remember, like we wait 3 months before we check TSH when we've started somebody on Synthroid. Is that?
Yeah, I'm a little faster than that. I tend to do the first check when I've changed somebody's dose or started somebody on new at about 6 weeks. And then after that, it stretches out. So the smaller the change I've made, the longer I'll let them go between rechecks until, somebody's really stable, and then they can just go once a year. Unless something, and I always tell them, look, if something changes, get your butt back in here and let's do it. Because everything that is fatigue is not thyroid.
Yeah.
And people get really hyper-focused, patients especially, get hyper-focused on thyroid because, I don't know if it's just sexy or whatever, or it's just something they've heard about. But there's so many, like you said, anemia. You mentioned anemia when you were in residency, making you tired. There's anemia. There's insulin resistance. There's, other horrible things. There's tumors. There's, you might have developed cancer. Oh my goodness, let's get you in and do a physical exam and figure out what the other symptoms are and figure out what's wrong.
Yeah. Not all fatigue is thyroid.
Not all fatigue is thyroid.
For your blood draws, does it have to be at a certain time of day? Like, is it more finicky because of the medications?
So, one of the big complaints that I get from patients who have been on thyroid medicine with other doctors and then come to me is my numbers are all over the place. First they're high, then they're low, then they're high, then they're low. And I'm like, well, do you go to the lab at the same time every time? And they're like, well, no, I go when I go to the doctor's office. And I'm like, oh, well, there's part of your problem because if you get a peak dose, so say you get up at 6 and take your thyroid medicine and then you go to the lab at 8, you're going to get a peak because 2 hours is a pretty good time when you're going to be at a peak level. Most endocrinologists, if you not take your thyroid medicine that morning, go to the lab first thing and then take your thyroid pills. So they're getting a trough. Well, if you're just checking a peak, then you're missing all the people that are low later in the day. If you're just getting a trough, you're missing all the people that are too high. And so what I tend to do is a mid dose. So if you get up and take your thyroid medicine at 6, then you're going to take it again approximately 12 hours later. Then go halfway between, go at noon to the lab. So that, and I push them, I say, go as close as possible to exactly 6 hours after you took your morning dose or when you regularly take your morning dose. And I ask them to the night before, make sure you took your evening dose 12 hours before you're going to take your morning dose. So, because I want it to be as exact as possible. And I tell them, look, make an appointment, get to the lab early, and then sit there in the chair and go, okay, I'm looking at my watch. Oh, now stick me. So try to get it as close on that 6 hours as they possibly can. And the closer they can get it, the easier it is for me to tell whether they're too high, too low, or just right.
Yeah. So by timing it like that, you're going to better be able to appreciate trends rather than it just being all over the place because you're checking different times of day.
Correct. Well, okay. So here's the thing. The T3 reverse T3 trend is not as finicky. But when I'm trying to figure out, okay, exactly how much T3 do I need to be giving a person, because that half-life is so short, I really do want that mid-dose as close as I can get it. If they're taking it 3 times a day, then I'll have them do it 4 hours after. If they're taking it 2 times a day, it'll be 6 hours. So halfway in between.
With your T3 and T4 that you're prescribing, So obviously that's going to help them with the symptoms, that we talked about, the, fatigue, hair loss,
Yes.
being cold, all these things. Does it do anything to the natural progression of the disease of Hashimoto's? Like, does it change the, what's happening from an autoimmune standpoint, or is it mostly just kind of helping with the symptoms that are related to that?
That's a really good question. So once you've got a patient feeling better and they trust you, then you can recommend other things like, here, I really think you ought to be taking these B vitamins. Here, I really think you ought to pay more attention to the standard American diet that you're eating that is destroying your pancreas. Because, here, I really do think you ought to start exercising. I really do think that you ought to start meditating.
Mm-hmm.
Here's how I think you ought to do it, blah, blah, blah. Because those are the things. Anything that reduces inflammation, reduces stress, is going to help that person reduce their tendency for high antibody levels and, antioxidants, all the things that lifestyle medicine doctors do to try to help their patients feel better. Also work on hypothyroid or Hashimoto's patients, because that disease it doesn't exist in a vacuum.
Do patients ever talk about surgery, just to remove the gland? I can remember at least a handful of patients, like throughout the years, who say, I have my endocrinologist.
I just want it out.
Like,
yeah,
my labs are fine, but I feel horrible. And, there's that. And there are some papers out there about, patients feeling better if you just remove the entire gland. What are your thoughts about that?
I kind of got a rep for helping people avoid surgery. And so I don't push them not to have surgery if they're like really, really determined. I have since a year ago stopped doing surgeries, but I have somebody that I really like local to me that I will refer to if we can't get them under control. But I mean, even your Graves' disease, I can get those people 4 out of 5 times. I can get them under really good control. And when you have a total thyroidectomy, you are now brittle. You are utterly dependent on the exogenous thyroid. And I spend a lot of informed consent time talking to people about the fact that despite the fact that your thyroid gland is jacked up, I'm just being vernacular here, it's still doing something. And it is helping keep you on a level to some extent. It also has calcitonin in there, which you need for bone health. And if you take all of that out, we don't really know the implications of not having a natural source of calcitonin in your body, because there's not good research on that. There's really not. And so I really, I don't force them to say, I'm not like, right. If you go have your thyroid out, I won't see you. I'm not forcing them away, but I'm also not pushing them to have surgery. I mean, even your Graves' disease, I do something called suppress and replace, where I will put them on the methimazole to suppress for the most part, suppress until their TSH starts coming up out of the toilet. And then I'll give them back the T3, because a lot of people on methimazole feel just like the Hashimoto's patients. They feel terrible. And I can see why they want their thyroid out if they feel terrible. A lot of people who already had radiation for their thyroid, I treat them too. So that's another big subset of people that I treat, is people who have had their thyroid irradiated either from head and neck cancer or because of Graves' disease antibodies.
So you feel like, even though it sounds like on the surface, it sounds like it might make it easier to take the gland out. Let's just take the gland out and then we can manage the hormones. It's not that. It doesn't necessarily make it easier to manage.
I don't think it makes it easier to manage at all. I think it makes more sense to get the Hashimoto's antibodies under control, which in 50% of people who have Hashimoto's, that happens without us really doing anything at all. It just naturally remits, and they're left with a gland that's, inadequately functioning. But the other 50%, a lot of times if we work with them and, get their diet under control, get their stress under control, their nutrition optimized, that sort of thing, a lot of times they will remit. And then we can just deal with what's left.
Are you doing most of your lifestyle counseling yourself, or do you work with, nutritionists and other people to kind of help with that part of it?
Right now, this is a brand new practice, and so I am solo. I'm doing literally everything myself. But I have a nutritionist who is also, she's great. She's somebody who has bad food allergies. So, and I forgot to mention that. So food allergies is another thing that I think can be a trigger for these Hashimoto's patients. And so when I send them to a nutritionist, I want somebody who's at least familiar with food allergy and preferably has personally experienced the pain of being allergic to, all dairy product or whatever. So yeah, a nutritionist is probably who I will pick first to add to my team as far as that goes. And then maybe an internist to help me look at the other stuff. So because insulin resistance is, oh my gosh, 80 million Americans have insulin resistance.
For, as we're kind of rounding things out, just thinking about, a lot of this information are things that I don't really remember learning in residency. Like we didn't.
You didn't. We were not. So we don't. We were not
really
taught these things.
do this with the medical management of these thyroid patients. So for people who are thinking, man, I think I'd like to read more about that, or I'd like to learn more about that. Like, how did you go about educating yourself to be able to take care of these patients?
Sure. So I mentioned my mentor that first explained to me, okay, here's how this works. Here's the papers that back it up. He is still in practice. He's semi-retired, but he's still in practice. And he teaches a course, and he has taught it at AAOA. He has taught it at the Academy of Environmental Medicine. And when COVID hit, he took it online, and I'm actually helping him do that. So it's a 12-week course. We meet every Sunday for 2 hours, and we don't just go through the thyroid stuff. The thyroid is probably 4 to 6 hours worth of online continuing ed, but he goes through the whole thing. He will tell you the insulin resistance, the bone health, the vitamin D, the sex hormones. He has learned it over the years. He has learned it all. His big claim to fame is all this thyroid stuff. And we are actually going to put that course online, and we're starting again on April 14th. Okay. So I am super excited about that.
So what's the name of the course, and what's the information for that?
The course is called The New Endocrinology, and it is available from my website, which is danagibbsmd.com. If you go into the For Physicians area and the courses area, you can find it.
Okay.
And I'm getting ready to put all the sales page and hyperlinks and all that stuff together. But right now you can reach it from my website, which is just danagibbsmd.com.
What's your mentor? Who's your mentor? What's his name?
His name is Alan McDaniel. His history is very, very interesting because he started out way back is a general surgery resident. And then he thought, okay, I don't want to do general surgery. And he did emergency medicine for like 2 years. And then he did a full otolaryngology residency and then an otology fellowship. And then he's very funny because what he says is, when I learned allergy, it kind of killed my otology practice because all these adhesive otitis media patients get well when you treat them with allergy shots. And then he said, and all my allergy patients get well when I treated their thyroid, so it killed it off too.
And then now with, the lifestyle medicine component of it, then that's going to just, everything else is going to fall away too.
Yeah, it's like you get so busy doing that, then you just don't have time for the rest. You don't have time to stay current. You don't have time to stay proficient. And so that's what he did during his retirement years after he finished doing ENT and allergy, is just all this integrative hormone stuff.
Very cool. All right. So I think, the discussion has been really great and informative, just kind of recapping with Hashimoto's. The big take-home points for me are about, kind of looking for those really super common symptoms that patients will have that maybe they're just attributing to their lack of sleep or menopause or what maybe they're just like, I don't know, this is just what getting old looks like, but actually talking to patients about, okay, like, are you tired? Are you cold all the time? Is your hair falling out? Kind of looking for those things, testing for more than just TSH, and recognizing the different types of medications that can be used beyond Synthroid, beyond levothyroxine.
Yes. And about the recognizing the symptoms, I will tell you, patients are smart and they are online and they are hearing about this stuff from naturopaths and chiropractors and other people who are putting themselves forward as doctors, but who are not doctors. And so they actually have a lot of education. But, when they go into their doctor and their doctor checks their TSH and says, you're fine, go away, they are really starting to lose faith in medicine. And so what happens is they've also because one of the symptoms of having this go on is that you get upper respiratory infections all the time. I mean, people stay sick, and that's a lot of how, as an ENT, that's how a lot of my patients came into me. Some of them would come in with thyroid nodules, but a lot of them would come in sick all the time. And then, like I said, we test them for allergies and not get a whole lot. And you might be the gateway as an ENT to say, okay, have you had your thyroid tested? And they'll be like, oh yeah, I had it tested. My doctor said, go away. And you can say, well, but there's more to it. And I really do think that I have run out of things that I can offer you as far as sinus surgery and this and that. Here, let's do this 5-test panel. And if it comes back abnormal, send them to somebody who knows what to do. If you don't want to, it's fussy and you may not want to mess with it yourself. Yeah. And that's one of the reasons I stopped doing surgery, is because I just did not have the bandwidth to do both. But send them to somebody who knows what reverse T3 is and treats with T3 and knows how to do it. Because that patient will, and I'm going to choke up again, but those patients are so grateful that they will almost literally fall at your feet and cry real tears because they have been misdiagnosed and misunderstood for so long.
Yeah.
And ENTs are in a really, really prime location to be a gateway into something better for those people.
And, as you mentioned, I think for a lot of, people who have a busy ENT practice, the management part may not be something that they're interested in.
They're not going to want to do that.
But let's say they live somewhere, they're not, in North Texas close to you to be able to send patients your way. And a lot of endocrinologists, as you mentioned, don't kind of subscribe to the same philosophy. So how do you find
That's absolutely true.
Find somebody to be able to kind of do that patient handoff? If you let's say you do this panel of tests and their T3 reverse T3 ratio is really low, and you're like, oh, I remember that podcast. I think this patient, maybe they do need that, but how do I find someone to send them to?
The first one would be to contact me and see if I know somebody in their state that'll do it. The second would be to look for an internist or a family doctor who subscribes to integrative medicine, and then if worse comes to worse, have that doctor call me and I'll help them figure it out, because I do an awful lot of that these days.
Very good. Well, this has been great. Anything else that you want to leave our listeners with? Did we forget anything? Did we leave anything out?
I don't think so. But if you see somebody who has the thyroid symptoms, remember that old saw about if you hear hoofbeats, it's probably not a zebra, but it might be a horse that's painted the wrong color. I don't know. And also, especially if you see that patient and they're on Synthroid already and they still feel terrible, then this is what's wrong with them.
Well, thank you so much for taking the time. This was fun. If you want to find Dr. Dana Gibbs or connect with her online, you mentioned your website is danagibbs.com?
My website is danagibbsmd.com. And I am also on Facebook. My practice is on Facebook. It's called Consultants in Metabolism. And then I'm also on Instagram, Dana Gibbs MD. So you can find me there too.
Thank you so much.
This has been really fun. Thank you so much for having me.
Thanks for taking the time.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.